Hello everybody, thank you for joining me today for patient assessment. We're going to go over some details of why you should do a patient assessment and why we should have a proper patient assessment and how to properly do a patient assessment and the key factors that involves of doing a patient assessment. Just to introduce myself, my name is going to be William Britton. I'm going to be your instructor today over on patient assessment. A little bit of background on me. I got about 10 years in emergency services combined between EMS and fire. I am a firefighter and also I'm a paramedic. Patient assessment. Patient assessment is gathering detailed information to paint a picture for others. So pretty much what you want to do is gather as much information as you can to paint a picture for others so that you can tell them what's going on with this patient, so that if the person's not there, that they can get a good idea of what exactly is going on with this patient. Different objectives that we'll look at for patient assessment. What is a patient assessment? Why is a patient assessment important? Why is the order of the patient assessment important? Why is it necessary to develop a method of assessment and use that method on the patients? All these are going to be different objectives that we're going to go over. They're going to get answered through the slideshow. Why do we do a patient assessment? It's so you can have detailed information of what's going on with the patient. Why is it necessary to develop a method of assessment? This is necessary so that each time you get on scene, you can have a routine of how you check out the patient. Make sure you don't miss anything. Make sure that it's detailed enough that you're looking at the patient and you know what's going on. Introduction. What are phases of a patient assessment? Different phases that you'll see is we're going to review of dispatch information. From the time that you get dispatched is when you start your patient assessment. Your scene survey, your initial assessment of the patient. Then you're going to get into a focused history of them, a physical exam of the patient, what's going on with the patient. Then you'll get more down to detail of a physical exam of them. Most of the time this is when you're in the truck or something, when you're going to get down to the nitty gritty of their skin color, the temperatures, things like that. And then you have ongoing assessments of what you assess vital signs and things and different injuries or things while you're en route to the hospital. And then communication with the hospital and other responders, and then documentation. Documentation is a big thing on patient assessment. You want to make sure that you are doing proper documentation and that your patient assessment will help you add detail to your documentation and help you improve your documentation. Differential diagnosis. Begin with the receipt of the call from dispatch. Your location, your incident, your illness or injury. These are going to be different things that you'll start with your patient assessment. You'll begin with where are you going? Is it a store? Is it a home? Is it the side of the road? What kind of incident is it? Is it a gunshot? Is it grandma fell? Is it a kids throwing up? Is it somebody just sick? What's going on there? And then illness and injury. Is it an illness? Is it an injury? That's pretty self-explained right there. Updated information. This is going to be information that you're going to get while you're en route to the hospital. Not en route to the hospital. While you're en route to the scene. This is going to be further information from the dispatcher. It might be a 35-year-old male. Usually it's going to be your EMD codes, like a 13 Delta 1, a diabetic unresponsive. Information from other units on scene. The fire department might get there before you, or another EMS truck, or your supervisor or something. They might give you detail that there's smoke or there's fire or there's lines in the road, that there's water. There might be some sort of hazard. So you should always listen to your communications on the radio while you're en route to the hospital, just to make sure that there's not en route to the hospital, while you're en route to the scene, to make sure that there's no issues. Upon arrival, when you arrive on scene, you want to do a scene size up. That's going to be your number one thing. No matter what incident you have, no matter what's going on, you're always wanting to do a scene size up. You always want to look around, don't rush in. Never jump off the truck and rush into something. You want to make sure your scene's safe. You want to make sure you scan over the whole scene. Make sure you know where the location of the victims are. And as I said, victims. Sometimes on traffic accidents, you might have more than one or two patients. You might have 4, 5, 6. You want to make sure that you have adequate number or adequate account of where each person is, and make sure that everybody who was involved in the incident is getting proper care. You want to make sure that you know what the mechanism of injury was. Maybe it looked like they were stabbed, but maybe they weren't stabbed. Maybe something else happened. You want to make sure that you know what is the possible mechanisms of injury. Scene size up upon arrival. What do you see? What do you see when you first get out? Not even when you get out. Like pulling up to the scene. Are you 5 miles out? Do you see smoke? Can you see something in the air? Is there something that you see? Some sort of hazard. Crowds are hazards. People can be in your way. You can have riots, hazmat stuff, electricity. Lines are down, gas, fire, glass. The stability of your environment. Is the environment stable? Is there people very irate on scene? And then always traffic. Most of the time when you're in an ambulance, you're always getting out on the road or something like that. So there's always going to be traffic around. So if this happens, you want to make sure that you're always looking for oncoming and passing traffic when you get out of the ambulance. Also with your scene safety, you want to ensure safety for yourself. Yourself and only yourself is the number one priority. You want to make sure that your safety is always the number one thing. Then it's your partner, other rescuers and bystanders, and then ultimately last is going to be the patient. Also, what you might need while you're en route. You might need other assistance. You might need more medical ambulances, a BLS unit, fire suppression, a heavy rescue, technical rescue, hazmat unit, law enforcement. You need to be thinking about this from either information that you get while you're en route to the scene or once you get on scene. These are different things that you want to make sure that you have coming to you, resources that you are have at your hands to utilize. You want to just make sure that you can call for these. Scene safety, personal and crew protection, BSI. That's like another big thing. No matter what kind of exam you do, no matter what kind of TSOPs or something like that, scene safety and BSI are like your two big things, and you can get failed at them if you don't do them. So BSI, body substance isolation. That's going to be your gloves, your eye protection, mask gowns, SCBA, hand washing. This is going to be the things that keeps you protected, keeps you from catching something from others, keep you from giving somebody something. You might have a little bit of cold. The patient's not always the bad person. Maybe you can give the patient something. So you want to make sure that we're taking these precautions to always make sure that everybody's being safe and that nobody's having body substance isolation issues. Another thing is going to be your PPE, protective clothing. Cold weather, winter's coming up. Everybody make sure you have your jackets. We haven't had no rain in a while, so we don't have to worry about our rain jackets right now. But the biggest thing is going to be the cold weather. Things are chilling off. You don't want to be out on scene for 5 hours and be out in the cold. Turnout gear provides head and toe protection. You want to make sure you have proper head and toe protection. If you're getting in cars, make sure you have proper turnout gear on. And then always we want to make sure that we carry gloves on, especially in the EMS world. You want to make sure you have gloves on to make sure you can perform your job appropriately. Other protective clothing, helmets, they must be worn in any fall zones. So any fall zones that you have, you want to make sure you have your helmet on. Boots, these should protect your feet, fit well, and they should be flexible. A lot of people will buy things that are comfortable. They make tons of boots now that are comfortable enough for you to wear, that are up to the standard of protecting your feet. Eye and ear protection, it should be used on rescue operations. Also, sun protection. We're kind of getting into the winter time, so it won't be as hot, but you'll still have the sun. Wintertime, you can get sunburnt, trust me. So make sure you're using sunblock when you're outdoors, even in the wintertime. Scene safety, personal and crew protection, violent situations. These are going to be different things that you need to make sure that you're keeping yourself and your crew protected at all times. Violent situations. You might get sent out to a civil disturbances, domestic disputes, crime scenes, large gatherings, depending on what type of gathering it is. It could be a protest or something like that. You want to always make sure that you're keeping yourself safe. Behavioral emergencies are another thing that we need to look at. Determine of the violence, any past history, any vocal activity, any physical activity. You need to watch these patients, keep an eye on how they're changing, how they're progressing. Just make sure you're keeping yourself protected. And the biggest thing, if you don't feel safe, you can always back out of the scene, wait for law enforcement. Hopefully they might be already there, and that's where we get into the resource of calling for our additional resources. Scene safety and personal protection. Make sure that we're getting our immunizations, our flu, hepatitis, tetanus, measles, rubella. So you want to make sure you're getting these immunizations so that we're not catching anything that somebody might have. Protect yourself to protect others. Your personal safety is one of the utmost importance. You must understand the risk of each environment you enter. If you are hurt or disabled, you have not helped the situation and you have made it worse. So if you get hurt in any situation, then you're not helping anything. You just made the whole experience a lot worse. So when you expose yourself, you expose your family. So anything that you might bring home from work, you can expose to your family. So you're always wanting to make sure that you keep things protected. Your initial assessment, inpatient assessment, we're going to go over initial assessment. The purpose of this is to rapidly identify and correct life threats, to identify those patients who need rapid evacuation, minimum time on scene to maximum care while en route. Your general impression using the facts gathered as you respond to the scene and what you see as you approach the patient. What is your first impression of the patient's condition? Is he sick? Is he not sick? What do you see? What's going on with this patient? What is the first thing? Is there a knife laying next to him? Is there a gun laying next to him? Has the patient got vomit on him? Are they bleeding somewhere? Does the patient appear to be having a fever? Does the patient appear to have a rash on them? Does it appear that the patient's having agonal breathing? There's different things. That's going to be your general impression. Using the facts that you're gathered while responding to the scene, and then what you see as you approach the person. And then your chief complaint. Your chief complaint's going to be what the patient's complaining of. Is the patient complaining of a headache? Are they complaining of eye problems? Are they complaining of a burn? Did the kid accidentally touched the burner of the stove or something while grandma was taking out the cake out of the oven? There are different things that can happen. So pretty much the biggest thing that the person's complaining about is going to be what we indicate as our chief complaint. Also, in your initial assessment, we're going to have the mental status. This is going to be the level of consciousness of the patient. So we kind of monitor this or evaluate this, as we call it, in kind of a couple different ways. Alert, verbal, painful, and unresponsive. AVPU. So alert. Pretty much a person that's alert is going to be able to tell you where they're at, who they are. They're pretty much talking to you. It's going to be nothing wrong with them, general stuff. Verbal. Verbal is going to be where they're kind of talking, rambling. Maybe things are not all together. They don't know exactly what's all going on, but they're still kind of making noise and talking to you. And then painful is going to be a person that's possibly unresponsive, but when you give them a sternum rub, they respond to pain. You pinch their toe, they respond to that. There's some sort of indication to a painful stimuli that this person's going to respond to. So that's going to be your painful. And then you're going to have your U, which is going to be unresponsive. Unresponsive is pretty much going to be somebody that's not alert, they're not talking to you. You can poke them with a pin in the bottom of the foot. You can do a sternum rub. Nothing's making these people respond. Ammonia inhalants, which you probably shouldn't use, Somebody's not responding to those. If this person is like that, then this is what we're going to call them as a U, as in unresponsive. So these 4 letters right here are very important and something that you'll see all through your career in EMS and fire and everything, and that you should use in your initial assessment to check the mental status of any patient. Identify life threats. Airway. Your ABCs, as we always talk about. Initial assessment. Airway. A. Control C-spine if there is trauma suspected, and open and clear and maintain your airway. You want to make sure that the person's airway is always open, it's maintained, that they're breathing. There's no foreign objects in the airway causing an issue or anything. So you just want to make sure that that's all taken care of. On the airway, you want to make sure that things are open. You want to make sure you're using the proper airway techniques. You want to make sure you're using the proper King airway, OPA, MPA, whatever it might be. You want to make sure you're using the correct one on that patient to make sure that you're getting the proper airway and to open it. Next thing we're going to look at is B, your breathing. You're going to look at someone's breathing. How many times are they breathing a minute? Look, listen, feel. Bare chest, if respiratory distress is apparent, look at the patient. Are they breathing? Are they breathing 1 time a minute, 2 times a minute, 3 times a minute? Listen to their lungs. Listen to it. Do they have wheezing? Do they have some sort of rhonchi? Do they have some stridor going on? Something. So you want to always make sure whenever you're assessing the breathing that you're listening to it. And then also feel. It does not hurt to touch the patient's lungs there and see if they're breathing in and out correctly. Maybe one side's not inflating as good as the other. Maybe the other side is. So just make sure you look at that and see kind of where you're at with the breathing and the feeling of the chest. Circulation. Circulation is going to be pretty much the blood flow of the body. Major bleeding, that's going to be your number one thing in circulation. Any major bleeding, you want to go ahead and take care of that. You want to control that bleeding. You want to make sure that you can control it so that these people aren't losing blood. Pulses, you want to feel for pulses in the wrist, in the legs, up in the carotid. You want to make sure these people have pulses. You want to make sure if they're rapid or slow, or if they're weak and bounding. So you want to just make sure those are always good. You want to make sure your radial pulse is always greater than 80 systolic, and you want to make sure your femoral are greater than 70 systolic, and that your carotid is greater than 60 systolic. So those are just some pointers there. ABCs. Biggest thing you can remember in your initial assessment, your ABCs. So we've been over scene safety, BSI, ABCs. 3 big things that you can look at. And then your mental status. Is the patient alert? Are they unresponsive? Do they have painful stimuli? Are they only alert to verbal? Also in circulation, you're going to look at capillary refill. How fast do the capillaries refill if you pinch on their nail beds? That's going to be an indication of blood circulation. Skin color. What do they look like? Are they pale? Are they cyanotic? Are they red? This is going to be another indication that you want to look into your initial assessment. And these should be quick. Like, you should be able to do your initial assessment in a quick minute. Like, you should be able to bam, 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 see all this pretty quick. You're going to know if they're breathing. You're going to know if they're red. You're going to know this. So you'll get a lot of this information in the first impression that you'll see of the patient. Temperature. Are they hot, warm, cool? Their skin condition. Are they moist, dry? Are they sweating, diaphoretic really bad? What are they? Any disabilities? Does the patient have any disabilities? Do they have any prosthetic legs? Do they have some sort of mental disability? Are they autistic? These are all things that you need to find out in your initial assessment to help you further help the patient and help you further progress your patient assessment. You want to make sure you expose their head, their neck, their chest, their abdomen. That's something you want to expose in your initial assessment. You want to go ahead and just expose those for a more detailed assessment. Another thing we'll talk about are rapid evacuations, considered an ALS intercept. Sometimes you might be on a BLS unit and you're going to need to intercept with an ALS because this person's crashing. If during the initial assessment you encounter a life-threatening condition that your interventions cannot keep this person alive, you should rapidly evacuate them to someone who can. So you should never try to go outside of your practice and never withhold proper medical care to somebody if you can't provide it to them. You should always call for another resource or get them to a resource that's going to be able to help them. Criteria for rapid evacuation. So things that you want to look for whenever you want to do a rapid evacuation for this person. Whether you're going to life flight them out or if you're going to send them, somewhere, or what you're going to do for this person. Poor general impression. If you look at this person and you go through them and they just have a horrible impression, pretty much if they're unresponsive, if they're not speaking right, if they're diaphoretic real bad, if they have bad burns, if something is going on and they just don't have a good appearance to you, then this should be a question for this is probably a rapid evacuation situation. Unresponsive, if they have no gag or cough reflexes. If they are responsive but unable to follow commands, might be a head injury, motorcycle accidents. Is the patient up walking around but they won't stop moving around, they won't sit down for you, they won't let you get their blood pressure. There's those people that are annoying that, they're fine probably in all, but they just won't sit down, they're worried about their car, their motorcycle, this and that. That's not the situation I'm talking about. I'm talking about you ask the person their name, they can't tell you. You tell them to touch their nose or to sit right there and they're wanting to get up and move. Things that they can't logically understand or comprehend of what you're telling them. This is where we're going to look at unable to follow commands. And if they can't establish or maintain an airway, that's going to be another big thing that you need to really look at in criteria for a rapid evacuation, and something that we need to look into this and say, hey, something's going on with this, so we need to take care of this patient. Difficulty breathing, which goes back to the airway situation, or respiratory distress. If the patient's having respiratory distress or difficulty breathing, they might need to go somewhere quick. You might need to get them on CPAP. They might need to have some sort of medication given to them. Something that you might not be able to do. They might need to be intubated or something. There may be something that this patient needs that you don't have that's going to cause them to be a rapid evacuation. Poor perfusion for the person. If they're having poor circulation of the blood, if there's uncontrolled bleeding like we talked about, major bleeding is going to be the biggest thing that you need to look at. If you can't control bleeding, then you have a situation going on. You're probably going to use tourniquets, something like that. There's something bleeding out there's something causing this patient to bleed out. So there's things that you need to look at. Severe pain in any part of the body. So if somebody's having severe pain, hip, lungs, ribs, the rib areas, shoulder, something like that. Have a broke femur, I'm pretty sure you'll be in some severe pain. They might need some pain medication. So if you're a basic, you might need to call for a rapid evacuation, or, for more resources to come and assist you with this person. Severe chest pain. This could be an indication of a STEMI, some sort of heart issue. And an inability to move any body part is going to be another major thing for a rapid evacuation. Complicated childbirths. This is going to be something that you should look at. Anytime that somebody's having a complicated childbirth, you should look into getting them to a resource that can handle it. A complicated childbirth could be, high risk people. Usually, most of the time, pregnancy women are going to know if they're high risk, so that'll be able to help you out. A high body temp above 104. Something you might see like this a lot is with pediatric patients. A lot of pediatric patients will go into seizures due to a high fever. So you'll see this is probably going to be a lot more into pediatric patients. They might need some medications. They're going to need interventions to bring down that temperature of 104 or 103 or something. Especially if the medications, if the parents have given them some ibuprofen, Tylenol, etc. or something, isn't working, then you're probably going to have to use another intervention to bring their core body temperature down and to break that fever off of them and get it out of them. Signs of hypothermia. Winter's coming up like we talked about. You'll probably get a few calls of hypothermia. You need to warm the person back up. Keep blankets on your truck. Keep hot packs. If you're out on a major scene for a long time, depending on if some resources around here does rehab, you want to keep coffee, hot chocolate, things of that nature. Things of that nature that will keep the person warm and from going into a hypothermic state. Severe allergic reaction, anaphylaxis, is going to be another thing for a rapid response or evacuation, as we call it. If somebody's airway's closing up, as we talked about before, airway is going to be a major thing. So you're looking at airway, anaphylaxis. Person's pretty much not going to be breathing or can't breathe, so there needs to be an intervention to help them breathe. So this is where you're going to need to get them to the resource that they need to be able to be taken care of. Poisonings and overdoses of an unknown nature. This day and time, overdoses are a major thing now. This is probably going to be one thing that I can say is probably not going to be a rapid evacuation, depending on the type of overdose. Most of the time, if you know it's some sort of a drug, then you're probably not going to have to worry about it. Heroin, meth, stuff like that. Whatever you give, not whatever you give, whatever they have taken. If you give Narcan now, a lot of people are giving Narcan to patients and releasing them. Kind of a conflict thrown up in the air. Depends on what your agency and different things are. A lot of people now, you see the Narcan's given. They're not on the truck yet. You're not en route to the hospital, so the patient don't want to go. They're in the right frame of mind at the time, so you can't really force them to go. Yada, yada, yada. They end up signing a refusal, and then you're probably back out in a week. That's probably going to be your one time that you're not going to have a rapid evacuation of an overdose patient, unless the patient's not breathing or that the Narcan or the medication that you give them does not work. So that will then turn into a rapid evacuation situation. And then you always have accidental overdosing and poisoning. A lot of the times you have young children will get into cleaning supplies under the cabinet or something, or think it tastes good, and sometimes some of the stuff will taste good to kids and they'll drink it, and then that just, I don't know why, but then next thing you know, you have some sort of a poisoning. Next thing we're going to look at is a focused history and physical examination for trauma patients. Pretty much the purpose of this is going to be obtain a chief complaint what happened to the patient. Your focus history, you're going to focus into the person a lot more. You're going to look at the history of the person, what medical problems do they have. You're going to look at a physical exam of them. You're going to go through and actually evaluate the person. What happened to the patient? Did they get in an accident? Did they get cut? Did they get stung by a bee and now they're having breathing problems? After you kind of figure out what happened to the patient, you want to evaluate the chief complaint. What circumstances surround this incident? You know, what circumstances caused this incident? What is the mechanism of injury? Is it a high-risk injury? So if they got in a car accident and they have a open femur fracture, is this going to be a high-risk injury? Yes, it is. What caused the mechanism of injury? What's the mechanism of injury? The car accident, obviously. Could have been the dash, could have been something come through the windshield, etc. You know, something caused that. And then what are the circumstances around the incident? You know, what's caused this chief complaint is pretty much what you're going to look into. And then you're going to conduct a physical exam of the patient. You want to, you know, physically examine the whole aspect of the patient. You want to make sure that you're just checking them out, making sure that you find any abrasions, any bruises, anything like that. And then you want to also obtain your baseline vital signs during a focus history or physical exam of the trauma patient. Anytime with a trauma patient, after that you want to reevaluate the mechanism of injury. Is this a significant mechanism injury? Yes or no? Was it a high impact wreck? Was it 55 miles an hour? Was it 95 miles an hour? Did somebody die in the accident? If somebody did die in the accident, this is probably going to be a significant mechanism of injury. Was it 20 miles an hour wreck? You know, was it somebody just tapped the back of the car while they were backing out of a parking place? That's probably not going to be a significant mechanism of injury. It all depends on it. It's going to be pretty much a judgment call most of the time, but you know, most of the time you'll know if it's significant or not. Is the patient unresponsive or disoriented? Can they participate in the examination? That's where we're going to go back up onto our mental status of the patient. Is the patient oriented enough and able to participate in the examination, to tell you information, tell you where they are? Do they know where they are? Do they know what's happened? And are they able to tell you any medical history of them at all? And then also another thing that you should look at to help you understand whether or not what the mental status of the patient is if they've had any drugs or alcohol. And this will take you back to, can they participate in the examination because they're under the influence of drugs or alcohol. So sometimes, you know, drugs and alcohols are going to change your judgment, ain't going to allow you to talk. If you're overdosed, you know, if you're drunk, you may be a little bit tired if it's the patient. You know, different things will cause you to not be able to participate in an examination for the person. Patients with significant mechanisms of injury, rapid trauma assessment. So if you have a patient with a significant mechanism of injury, like we talked about the open femur fracture, you're going to perform what we call a rapid trauma assessment. Rapid trauma assessment is going to be pretty much a head-to-toe physical examination of the person. You're going to palpate all the legs, any injury sites, pretty much the whole body you want to palpate. You want to listen to lung sounds. You want to make sure that their senses are working. Make sure that they have sensation in their fingers, toes, in their extremities, wherever the mechanism of injury might be. You know, wherever there might be injuries, you want to make sure that you they have senses there. Make sure they have pulses. You want to make sure they can move things. But you also don't want to move things if it's injured enough that it's going to cause greater pain, or if it's going to cause greater injury to the patient. You don't want them. You don't want to make them do anything that will cause that. So, also looking at patients with significant mechanism of injury. With the rapid trauma assessment, we have kind of a little step that we'll do with the rapid trauma assessment that you can look at. When you're going down the patient, you know, when you're looking at their body, you want to indicate DCAT BTLS. This is going to be something that you'll use as you're going through and looking at the patient. Do they have any deformities? Do you see any deformities to the legs, to the arms, to the neck, anywhere on the body? Do you see any deformities, any contusions? Like we talked about, contusions, abrasions, punctures or penetrations you want to look for, any burns on the patient, any tenderness whenever you palpate down through the patient. Like we said, from head to toe assessment, you want to make sure there's no tenderness. Do you see any lacerations on the patient? So these are all things that you're wanting to look at as you're doing this assessment on this patient. Do you see any swelling, or is there any swelling on the patient? Edema patients, you'll probably see some swelling in their feet and everything. So this is all an indication of things that when you're doing your rapid trauma assessment down the person, what do you see? Punctures or penetrations. Do you see any burns, tenders? Is there anywhere tenderness whenever you're touching? Are there any lacerations, and is there any swelling? Also, the next thing you're going to do anytime you have a significant mechanism of injury, you're wanting to make sure that you get you want to be quick enough and obtain a baseline vital signs. More than one set. You're looking for a trending. You want to get trending vitals, so you want to take more than one set. So about every 5 minutes for a trauma patient, as we're going to say. Maybe every 3 minutes, depending on what the situation is, but at least a minimum of 5 minutes that you want to get vital signs on the patient. You want to keep an eye on that blood pressure. You want to keep an eye on that pulse. You want to keep an eye on the breathing rate, the respiratory rate. You want to make sure that nothing's changing. You want to make sure that all those are staying stable. The O2 saturation staying up. That's not dropping. So that might be an indication of that there is something else going on with this patient, and that maybe you need to take further action on this patient. You might need to do other interventions to prepare this patient for another situation that might be arising. Patients with significant mechanism of injury, you're going to use the sample method. This is a pretty simple method. This is actually you can use on anybody, and it's a good idea to use the sample history for anyone. The S is going to be signs and symptoms. What are the signs and symptoms that the patient's having? Does the patient have any allergies? Do they have allergies to any medications, any food? Are they allergic to any bee stings, anything like that? You want to make sure that you kind of get that information so that you know that you're not giving a drug or that you're putting this person in harm's way because they're allergic to something. If you can get that information, that's a good thing to always do. Medications. Sometimes it's hard to get medications, especially on unresponsive patient, unless you're at their house and maybe what they're taking. Things you can ask: are you taking anything? Ask the patient what they're taking. They might say, yeah, I'm taking this little blue pill or this pill. Of course, we all don't know drugs that good to where we know that every little pill color and exactly what they're talking about. Thing I like to always do is when I ask them about medications, because they'll ask you, is always to ask them, well, what do you take medications for? Are you taking something for a blood pressure? Are you taking a water pill? Most of the time they'll tell you that, and kind of indicates you kind of in the right family or kind of the right category of what they're taking medications for. You want to find out when did they last take medicine, especially if they're having abdominal issues, anything like that. You want to make sure you know when the last time they took some medication, especially if they're kind of a little drowsy or something. Maybe they have a prescription for a narcotic or something that's making them a little woozy. Maybe they took some sleeping medicine, so you want to make sure you know when they took it. What are they taking? What are they for, like we said? And then also, if they do have them, ask them if they have the medicine. Ask them if you can physically look at the medicine and see if you can determine what it is. The P, previous medical history. Pertinent. You want pertinent medical history. You don't want, well, I had a toe cut 20 years ago because I fell out of the apple tree at grandma's house while trying to pick an apple, but then grandma took care of it. That's not going to be pertinent. No, pertinent will be like, I have congestive heart failure, I've had a heart attack before, I've had a stroke, things of that nature is going to be pertinent. Things that are related to this complaint, previous medical history that might relate to this complaint, like maybe they had a car accident we talked about. Well, person's a diabetic. I'm a diabetic. Well, their sugar's 20. That's a good indication of why there's a car accident, probably because their sugar's down in the 20s. And any complicating factors that might make things complicated for the situation that the patient might have that's been a previous history, behavioral stuff like that. Maybe the patient's aggressive because they've had a bad bad experiences with law enforcement or something. That's something to keep in mind. Not really with a significant mechanism of injury, but anytime you are on scene with a patient like that. Your L, last oral intake. So another good thing, especially for any kind of significant mechanism of injury, is the last oral intake. So you want to know when's the last time they intook any food, drink, water. You want to know what it was, when it was. Maybe they're throwing up something. You kind of want to know what they've had to eat, so if it's the right stuff coming up. If they're throwing up red stuff and they had some red Kool-Aid or some cranberries or something that was that color, maybe it's not blood, maybe it's what they ate. So you might have a good idea of kind of what that is. The E, events leading up to this incident, what happened and when. So what were the events that led up to this? Was the patient driving down the road? Like we said, our diabetic patient, their sugar dropped. That's what caused the accident. So that was an event leading up to this incident. When did it happen? When did this start? If you're having chest pain, if you had chest pain, did the chest pain start 5 minutes ago? Did it start 30 minutes ago? Did it start 2 days ago? Some people, their chest pain's been going on for 2 weeks, been going on for a year. Somebody, it just all depends. So it's always good to know when this started and when this happened. Patients with no significant mechanism of injury. So these are going to be a little bit different. You're still going to do kind of the details and stuff with them, but you'll assess their chief complaint first, and then you'll do a focus assessment on them. You'll get some baseline vitals, and then we're going to use our sample history on them. So pretty much you're going to do chief complaint is, I'm sick, I've been nauseated. Okay, we're going to focus, look at them. You're going to look at, is the patient responsive, yes or no? We're going to be using our AVPU. Back like we'll look at it again. It's probably going to be our alert, verbal, painful, and unresponsive. You pick one. Which one is the patient? Most likely, if there's no significant mechanism of injury, they're probably alert. They're probably talking to you. They can probably give you all the information that they need to be able to give you a pertinent medical history. Responsive patients under medical, assess their chief complaint, their signs and symptoms. Another thing that we'll use for medical patients whenever we're looking at their signs and symptoms, if grandma's sick, when did she have the onset? If she has chest pain, when and how did the symptoms begin? This is what we call OPQRST. Onset, what provokes it, makes the symptoms worse. Signs and symptoms as we go through. Quality, how do you feel? Describe the pain. What does your pain feel like? Do not lead the patient ever into what the pain is. So give them multiple choices of what the pain is. Is it dull, sharp, stabbing? Never give them one. Don't say one thing. Never lead them down a path. Let them tell you what's wrong with them. And then radiation. Where is the pain? Does the pain travel anywhere else? Does it go up the shoulder, into the neck, or anything like that? And then you're going to have the severity. How bad is the pain? Is it on a 1 to 10 scale? 1 being the lowest, 10 being the worst. So kind of get them to kind of tell you kind of what the pain level is. Also, pain level, some people can take pain better than others, so don't ever discredit their pain level, because you never know. And then time. How long have you been having the symptoms? Document the actual time that it started. Make sure you put that in your documentation of when their pain started. Sample history. Like we said with responsive medical patients, we're going to have sample history, focused medical assessment, baseline vitals. Then you're going to need to make a transport decision. How are we transporting them? Emergency, non-emergency? Probably to a critical care hospital. Are we going to a basic hospital that can just handle a sick person? Figure out what kind of place or what resource that you need to take them to. Do they need a cath lab, etc.? So just try to figure that out. And then while you're en route, do a detailed physical exam. So you want to go through and make sure you check everything: their eyes, their nose, their ears. Pretty much we're going to go from the head to the toes again. And then while you're en route, you're going to continue doing your ongoing assessment of getting your vital signs and checking in on anything that was wrong with them. Unresponsive patients that are medical, rapid medical assessment is what you're going to start with. You're going to have baseline vitals that you're going to need. You're going to do your sample history. Most of the time you have to get this from family and coworkers or a bystander for the most part. Then you're going to transport. Most of the time this is going to be a rapid transport. You might have to do a rapid evacuation on these patients. It all depends on what's going on. And then while you're en route, you're always going to continue to do your ongoing assessment of vital signs and monitoring the patient. A detailed physical exam. So when you get into a detailed physical exam, it's going to be a more detailed head-to-toe examination. They're usually time sensitive, and usually they're performed while en route. So usually while you're going en route to the hospital, you're going to be doing a more detailed. That's where you're cutting clothes off. You're looking for exactly every little thing that might be wrong with the patient, and this is probably when you're going to do a lot more interventions that might not be as much as life-threatening as your beginning assessment. So you might have a open wound that's blowing out blood. You wrap that up. So this might just be a little abrasion or a laceration there that needs a little band-aid or something on it. That's going to be more into your detailed physical exam that you usually see. Detailed physical exam required for any unresponsive patients. So anytime you have unresponsive patients, you need to do a detailed physical examination on them. If the patient cannot communicate what is wrong, you must seek out the problem. So you need to find out what's going on with the problem. It's required for any multi-trauma patients. So victims of multi-trauma must be assessed for less obvious or masked injuries. So you want to make sure you know what is going on with this person. Also, a detailed physical examination is required for any patient with significant mechanism of injury. So if the mechanism of injury could have caused serious injury, the EMT must activate access to access for additional injuries. So you need to get them to where they need to be going. Your ongoing assessment, the purpose of that is to determine if there are any changes in the patient's conditions. You're going to identify any missed injuries or conditions that you may have overlooked a little bit. You're going to assess the effectiveness of treatment given and adjust it if necessary, to keep the person regulated. Ongoing assessments are going to be performed on both the trauma or medical patient, no matter what. The procedure is going to repeat initial assessment. You're going to reassess your vital signs. You're going to repeat a focused assessment, and then you're going to check interventions of what you've done. Make sure that everything that you've done is still in place, that it's still working properly, and make sure that it is working efficiently for the patient to help them. Go big or go home. Error on the side of caution. So the biggest thing with patient assessment, as I can say, is that no matter what you do, just always err on the side of caution. Always work with the patient's best interest in mind, and you'll pretty much be fine. So as long as you're treating the person as if it was you or one of your family members, you most likely will be fine. If you're not sure if the person has a broke arm, it's not going to hurt to splint it. Go ahead and splint it. You know, if you think that they need a bandage on a small cut, do that. If you think they need to go to a trauma center because they might have a possible broke leg or the burn or something, go ahead and call for the additional resources. The biggest thing that can happen is for you to need a resource that's not there, or a resource that you can't get because you hadn't called for it already, and something that you need right then and there. So the biggest thing I can tell you is to always just side, you know, just always be on the side of caution, and always keep the patient's best interests in mind. So that's the biggest thing with patient assessment. If there's any questions, you know, you can contact me through my email or any other way. I'm happy to answer any questions, get the slideshow to anybody. We can go over some other things. So I appreciate everybody watching the slideshow, kind of going through this presentation on patient assessment. Hopefully it gave you some key insight and maybe a slight refresher on this. So hopefully everybody enjoyed it, and if you have any questions, I'm here to help you out anytime. Thank you.